I too am Canadian, but I'm not a health economist. So I think the design of this is to be the intellectual thorn between two roses, since, just by definition, I'm not supposed to know what I'm talking about here, about health economics and the triple aim. So just to enhance the paradox, I'm actually going to talk a fair bit about health economics methods, what I regard as current and what I would hope to be the future. And I've taken the question quite literally, but I do believe it follows quite nicely on a lot of what Cam was saying, which is, what can health economics do to convert the triple aim into something resembling a reality instead of a high-level aspiration to remind us about certain features of health and life that we might want to remedy? So, being at the introductory level of this discipline, and in fact not being a health economist, I would just make a couple of observations about what I understand about health economics to be, and which is, first of all, I say this only half in jest, it's a lot easier than standard economics, because standard economics has to deal with supply and demand, and in health economics you just have to deal with supply, since that entirely drives what we do in healthcare. You can dispute that. But it is a remarkably supply-driven phenomenon, and I believe that is part of the phenomenon that gets us into the, I think in some ways appropriately cynical, dark side Scottish view of the universe to a certain extent. And what it means, and we had, if you were in the session yesterday about, an introduction, what is health economics, I don't claim to be able to define it, but the key factor about economic thinking is that it places value on phenomena. And it can be a monetary value or a non-monetary value, but ultimately the great contribution of economic thinking to the problems of life is that it creates a currency called value, where we can begin to distinguish what we're getting for what we're investing. And again, the currencies can be monetary and non-monetary. And I think that's extraordinarily useful and extraordinarily applicable in the fix that we're in a sense. And when I say we're in a fix, it's because, exactly as Cam says, when you have in the triple aim lower costs, better patient experience, and better population health, number three, even in places in the world where they take this much more seriously than we do, they're real social democracies and they have a real whole of government, whole of society conversation about reducing disparities. And in fact, Scotland probably takes it as seriously as anyone. If you read a Scottish health report, it is expansive, it is intersectoral, it is everything you'd want it to be intellectually, and yet, if you look at Scandinavia, if you look at Scotland, if anything, disparities are growing. And if any of you read the European Observatory Machenbach work on health inequalities, this seems to be an intractable problem. So what can health economics do to convert aspiration into execution? So I'm going to go through these briefly, each of the three triple aims, and then I'm going to conclude with what my fantasy world of health economics would illuminate to start to move us forward. So, what about, let's take population health and health disparities. So why is this, at this point in our existence, quite sincere, I believe, but nevertheless still rhetoric? Well, I think what we need to do, and what health economics can help do, is unpack exactly what's going on in our collective preferences about where we want our money spent. So, for instance, when we say we value reduced disparities, it's compared opportunity cost alongside we also value access to health care and we value the receipt of health care. The other dimension of this is twofold. One is, comparatively, how much do we value improved health among anonymous persons, even if it is a lot of improved health, versus improving the health of ourselves or people we know with names and faces? I think there is a different value placed on that. I think we can say in our brains, yes, it would be great if the bottom quintile had a life expectancy increase of a year and reducing the disparities with the top quintile. But if you say, well, would you prefer that outcome if it meant 10% fewer hip and knee replacements or longer wait times? I think that's where you have the values conflict. But what we need to do is quantify what that is. Is it real, first of all? And secondly, how real is it, and what is the magnitude of that effect? The other dimension, which I think applies both within healthcare but also particularly in the realm of population health, is time. How much less do we value a future better state than a current or immediate and very tangible improvement in the short run? So if 100 people experience a big improvement in SF-36 scores after a surgical intervention, how much do we value that more than 100 people who have an additional quality adjusted life year that plays out over 15 years? It's the old, how much do you value intervention now versus secondary prevention later, for example? Or how much more do you value a healthcare intervention and effect within 30 to 90 days versus a social intervention that would have a head start-like impact? And you'll note that even when we have very good evidence that these social non-medical determinants of health investments generate a massive benefit and an excellent return on investment in the long run, we still don't spread those programs. Now, you can either say it's because we're perverse and we didn't mean it, or you could say there's something going on there from a values perspective and how we are wired psychologically to think about these things that prevents us from making what would seem to be obvious reinvestments. So health economics, I believe, can really dig deep on what those value distinctions are and what the discounts rates are for anonymity in time. And I think some health economics does that, but I think we need to go a lot deeper if we're going to try to find what inhibits change, what prevents us from doing what we think intellectually we ought to do. So let me now turn to the improved patient experience. And again, I think health economists and others have done a relatively good job on advancing the science of what the patient experience is. Now, the patient experience has two dimensions. One is patient satisfaction, literally, with the experience they went through, and the other is quality of care. We are much better at measuring both than we were 15 years ago. So I worry least about whether the methods are developed to measure the patient experience, with one exception. And this isn't a methodological issue so much as a how much are you willing to pay to find out different things issue. We tend to end the conversations either on discharge or 30 days or maybe 90 days, and in rare instances a year after the healthcare intervention. In a world of chronic diseases and comorbidities, I think it has to be longer, and I think it has to be a little more multidimensional about what those outcomes are and what the experience is, and again, putting a value on it. And I don't mean a hard-headed necessarily, everything must be monetized and computed that way, but I do think that it is very important to start thinking in those terms because of two factors. One is, how much extra should we be willing to pay, we be willing to pay in order to achieve a better patient experience in the non-technical outcomes of care sense? That is, that the environment is better, that the general experience of the episode of care is better. Secondly, how much of this is resource dependent and how much isn't? I mean, it would be very useful to have health economists study, for example, can you get an improved patient experience just by educating providers to behave differently and to communicate differently and interact differently, as opposed to if you have 0.4 extra nurses per ward, you're going to get a better technical outcome, which is a lot of what the research is frankly designed to show and therefore does. So I think health economists could do us a great service by digging a little bit deeper on those dimensions of what doesn't cost money and what does it cost to achieve benefits at the margins where it does cost money, and how does it play out over time. Now let's turn to the third triple aim, which is, and it's very interesting how we've already weaseled out on this one in Canada. It literally says, the triple aim, lower costs. But we say lower rate of cost escalation because that's easier to swallow than lower costs. But the triple aim US version says lower costs. And you may say, well, they should have lower costs because they're blowing 6 points of the GDP unnecessarily on healthcare. But we're also blowing points of the GDP unnecessarily on healthcare, which raises the paradox. Economists talk about scarcity. But is it really legitimate in this context to talk about scarcity when every advanced healthcare system in the world shows quite literally zero return at the margin if the return is measured in either population health status and, as I would argue, even patient outcomes? On the theory that our healthcare systems are so abundant that we do a lot of unnecessary stuff. So the zero return is a function of we're doing all the essential work, but we're also doing work that is useless, which comes at a cost, and that is harmful, that comes at a greater cost. So I think health economists need to have a much richer discussion of what we mean by scarcity in healthcare. And if scarcity is simply someone will line up for something and agree to undergo it if it is offered to them, yes, technically that's scarcity. And it's also technically scarcity if the system is running at full capacity and there are still people waiting for care. But if you add the dimension that we haven't tackled appropriateness and we haven't tackled variation very well, I think we should be agnostic about scarcity. And the triple aim, in fact, pretty much telegraphs the game. You know, the triple aim isn't saying you should have lower costs and harm people by not giving them essential health care in order to produce the greater good through social investment. It's really saying we waste 30% of healthcare spending. That's what it says. We waste 30% of healthcare spending. If that's true, if it's half true, if it's only 15%, we still don't, in my view, we're still not using the term scarcity in the way I think it ought to be used. With that aside, there are other contributions that health economics can make, especially in our context. One is, which again I think that they're doing quite well, is there are more sophisticated conversations and analyses about price. You know, cost is price times quantity. There's lots of work to be done on quantity. There is lots of work to be done on price. And we're beginning to get into price. I mean, the provinces are now admirably colluding to whack generic drug pricing after 20 years of not doing the obvious. And there's lots of other things to do. The price of labor, which doesn't mean that you should pay nurses less. It should mean we are using a whole lot of healthcare personnel working at the bottom of their scope of practice, not the top. Division of labor, an inappropriate, in my view, division of labor, or I guess to put it more neutrally, an inefficient division of labor, costs us billions of dollars. We should quantify this. Health economists should actually study this and tell us how much actually are we paying extra because registered nurses are doing work that licensed practical nurses could do and that GPs are doing work that nurse practitioners could do. You know, these things have been studied, but we haven't quantified it. The other thing that hasn't been quantified is how much does it cost when a profession raises its entry to practice credential from a baccalaureate degree to a master's degree, and is the added benefit worth the added cost? What is the impact on intention to enroll? Which socioeconomic status classes, which social classes no longer enter those professions because the training program has moved to a university and is now much longer? How much, to answer the central question, has it cost Canada to move from diploma to baccalaureate entry to practice for nursing? My back of the envelope estimate is billions of dollars. Don't believe me, but you should want to know. And I think health economists should actually start doing these labor force studies a lot more deeply and a lot more comprehensively. However, again, on the lower cost side, if you just used the inventory of very high quality health economic studies that show we're getting poor value, we would do well, and I salute the health economists for having produced them, and I lament the fact that their wisdom has not been translated into the system. Which brings me to the central part of what I want to say. What, in the end of the day, is health economics about? Is it a descriptive science? That is, it can describe what we say are our values. It can elicit value preferences. If you give people options, would you rather have a knee replaced, would you rather, versus a counseling session, versus a new hospital in your community, versus a new nursing home in your community, people will give you an answer if you make them. And it will elicit what their values are. But if you say to me, what is your rank ordering of these various options? My proposition is my rank ordering might change if I had different information. If it is framed differently to me, or if my state of ignorance is reduced by information, my values might change. So let's go back to the central question for the triple aim, which is, do we really take the population health goals seriously, and particularly the reduced disparities? Well, I may say unreflectingly, no, I'm not that interested in that because I'm more interested in this. I'm more interested in a new MRI machine for my hospital. But under what conditions are my values modifiable? And to generalize that, under what conditions are society's values modifiable so that they create a politically legitimate warrant for the kind of change that population health wonks like me think ought to happen? It's very interesting. If you teach, which I did on one occasion, if you teach a class in health policy, and you teach people going through a Masters of Public Health program at Simon Fraser University, you have 27 diverse students, and every one of them would want massive reinvestment in the non-medical determinants of health. But society doesn't. So the disjunction is either you could say only self-selected social democrats go into population health, which I don't believe, although it's partly true. But it could be that once you get more information and a richer information base about both the limits of what healthcare can do, the vanishing returns at the margins from healthcare, and the albeit long-term and messy positive effects of population health interventions, you tend to want those. Well, is the problem that you can never inform the public differently so that it might reframe its choices? Or is the problem something else? I think health economists should really get involved in the study of modifiable preferences and what it takes. It's still a description in a sense, but the whole notion of framing effects, when does information actually start to make a difference? What are the prospects? How much do people value having this information and so on would be very useful. Related to this is the issue of intrinsic versus extrinsic motivation. I think one of the disservices that classical economics does is it tends to portray human beings as rational actors who have only one thing in mind, which is their own utility maximization, and that it's always externally modifiable. That is, you throw out a carrot and you'll eat it, you show a stick and you'll run away from it. I don't think people are that simple. I think the Daniel Pink type of research and so on shows that people are actually not motivated strictly by those extrinsic and narrowly framed motivations at all. And I think on the provider side, we have made the great mistake of framing our public policy, our collective agreements, in monetary terms. The only thing we think is going to change physician behavior, or nurse behavior for that matter, retention rates, patterns of practice, is if you fine-tune your economic incentives. I think it's wrong, frankly, and I think it's somewhat insulting to the people involved in it. So I would like health economists to actually take that broader lens about motivation, focus as much on intrinsic motivation as extrinsic motivation, and see how it plays out. So in summary, I would say that the more that health economics marries itself to psychology, behavioral psychology, and the final one is public policy and politics. So, for instance, it's commonly said that what governments value above all, and that's why things don't change, is peace. So governments don't want to fight to make the changes that they intellectually want. Health economists could help us understand what is the value base underlying that. What does it mean to say they value peace? How much peace? And at what cost? I actually think this is a studyable phenomenon, and I think if health economists combined with political scientists and psychologists actually got into that kind of public policy psychology and value preferences, it would be a breakthrough too. So that's all I got.